That BIMSSCON will continue to deliver such fantastic content going forward. Today's topic will be on acute respiratory failure. In the light of COVID-19, this has become a topic that is very important for everyone to know, regardless of specialty, regardless of level of one's medical education. And hopefully we will talk about that today. Okay. So acute respiratory failure. What is acute respiratory failure? So just like any other organ failure, respiratory failure is a failure of the lungs or failure of ventilation, to be more precise. To give an example, when we think of renal failure or kidney failure, we imagine that the kidneys are not producing enough urine, they're not filtering properly. And that's why we see a rise in urea, rise in creatinine. That's what happens with kidney failure. When we think of heart failure, we feel that the heart is not contracting enough. It is not doing its job. When it's left heart failure, the left heart is not contracting enough. When it's right ventricular failure, the right heart is not contracting enough. So it's very easy to understand. And for some reason, people seem to have better idea about heart, liver, or kidney failure than respiratory failure, even though it is possible that actually you might get respiratory failure with all of the other failures as well. So the definition of respiratory failure is an acute, if it's acute respiratory failure, which we will be talking about mainly. The definition of respiratory failure is that it is an acute problem, acute deterioration of gas exchange, of ventilation, which causes hypoxia. So you have oxygen levels that come down in the blood because of a failure of the respiratory system. And this can happen due to multiple reasons, which we will have a brief discussion about later. However, what we want to understand here is what it is to begin with. So respiratory failure is not necessarily having a lung disease. Someone can have very severe pneumonia without necessarily having respiratory failure. Someone can have quite severe COPD without necessarily having respiratory failure. Respiratory failure is that acute phase when an acute illness causes one to develop hypoxia, and along with hypoxia, because of a ventilation problem. Now, this can happen due to two reasons. One is obviously difficulty in breathing. If someone cannot breathe, if someone cannot get enough oxygen air in, that would be a cause of respiratory failure. Whether it is because someone is not breathing enough, for example, morphine overdose, opioid overdose, heroin overdose, and they're not just able to breathe, they're not ventilating enough. That's one. It could be because there is a block in the airway. Maybe there's anaphylaxis, this airway has swollen up and people cannot breathe anymore. It can be due to the fact that people have other neuromuscular dystrophy or some organic problem which is preventing them from breathing cleanly. That is problem. There's one way one can develop respiratory failure. The second way we can develop respiratory failure is obviously if the ventilation is going okay, but the perfusion is not right. So if there are problems in the alveoli which prevent prevent the gas exchange onto the blood. So things like if you have a pneumonia, if you have a COPD where your lungs are just not good enough, they're not contracting well enough. That is another. So there's a ventilation problem, whether the lung is not contracting well, whether the alveoli is not allowing gas exchange. And the third thing is if we have a circulatory problem, a circulatory shunt, if we can call it. So things like pulmonary embolism, for example, will not allow enough blood to pass through the lungs or will cause less blood to pass through the lungs, and so less gas exchange will happen. So respiratory failure can actually happen due to causes which are completely out of the lungs as well. Another example being if someone has an acute myocardial infarction and develops pulmonary edema. If they develop pulmonary edema, people develop respiratory failure not because they cannot breathe, and they can breathe, but because the lungs cannot expand because of all the fluid in the lung. So that is how we think of respiratory failure. Broadly classified, it is classified into 2. Sadly, we call it type 1 or type 2 respiratory failure, which isn't very helpful for medical students, because this is the kind of thing that you make a mistake in the exam because you forget which one was type 1 and which one was type 2. So type 1 respiratory failure is where we have hypoxia. There is a lack of oxygen, and that is the primary problem. Type 2 respiratory failure is when there is hypoxia as well, but along with that, there is hypercapnia or hypercarbia, however you call it. Basically, the oxygen is low and the carbon dioxide is high. What are the measures? Unfortunately, the best measurement for any kind of gas exchange problem is an arterial blood gas. And in an arterial blood gas, the partial pressure of oxygen that we aim for is greater than 60 millimeters of mercury or 8 kilopascals. In the UK, we often use kilopascal, but I know internationally most places will use millimeters of mercury. So I will try my best to keep both on. And in terms of hypercapnia, the targets are usually partial pressure of carbon dioxide will be greater than 6.5 kilopascal or greater than 50. So these are the usual acceptable markers. Some people will have individualized differences depending on how sick or not sick they are. Now, coming to the two types of respiratory failure, we've talked about type 1 and type 2. So if we speak about type 2 first, because that's actually easier to define, and then we can come back to type 1, because type 1 can happen for any number of problems, whereas type 2 is a defined problem. It happens for very specific reasons. The most common being infective exacerbation of COPD, or long-term COPD patients who are chronic hypercapnic, chronic carbon dioxide retainers. So the reason we have type 2 respiratory failure is because there is not enough ventilation. There's not enough ventilation to allow the carbon dioxide in the body to be exhaled out. They might have normal oxygen, but their carbon dioxide is really high. And that happens most commonly with COPD patients, but we will often see that in late stages of neuromuscular disease, some patients with obstructive sleep apnea, if they're really obese and they find it difficult to sleep. Again, it's a ventilation problem, so they cannot pass enough air in and air out, and that is why they have this problem. And actually, in most patients who develop type 1 respiratory failure, unless you treat them properly, they will go on to develop type 2 respiratory failure. Now, that is the definition, that is how it presents. Now, how do we assess a patient? I am a trainee in emergency medicine, and emergency medicine practice, it finds that we actually assess a patient. There is the urgent initial assessment, and then you go back to what you guys learn in medical college about taking a good history, doing a good full examination, and doing the full investigation protocol. What we do, the first initial assessment is called the ABCDE assessment, which you might have heard of. ABCDE. It's easy to remember. A is for airway, and that's actually very important when we spoke of initially. So when you see a sick patient, you try to see if their airway is patent or not. If they can talk, that's great. If they cannot talk, you might have in their mouth. I recently was asked to actually go and see a patient in the emergency department, and initially the thought was that this patient has got respiratory failure, which it was true. She did have type 1 respiratory failure. However, the problem that happened was this elderly lady had small intestinal obstruction. So because of intestinal obstruction, the lady started having fecal vomiting. And because of the vomiting, that vomit was stuck at the larynx. So when the anesthetist, because when she was completely losing her airway, the anesthetist came to intubate the patient. The anesthetist was saying that there was a lot of fecal matter at the base of her airway. And the only way we would have known actually that the airway is blocked, but if you open the airway and actually look, people can have something, especially with kids, they will have something stuck at the back of their throat. If you just remove that, that's it. Their hypoxia is gone. The respiratory failure will get better automatically. Sometimes the other common one with airway obstruction is anaphylaxis. If someone has an allergic reaction, a severe allergic reaction, they will often develop anaphylaxis And then anaphylaxis can give tongue swelling, they can give throat swelling, and they will have an airway obstruction as well. Again, if you can remove the airway obstruction, they will be fine. Whether you give some adrenaline or you can put a airway inside. Now, if the airway is a bit, so for example, if it's a stroke patient who cannot maintain their own airway, but they don't necessarily need to be intubated, and I must say this, but a lot of your management will depend on the resources you have. In Bangladesh, for example, your management will differ between a private hospital in Dhaka versus an Upazila hospital, in, there will be different because of the resources you have. And now there are lots of different ways in how you can have different airway adjuncts. So for example, every one of you will know, going to medical college, you have the nasopharyngeal airway, which allows your airway to stay open. In a lot of patients who are a bit sedated, that's actually quite good enough. Sometimes you can put in an oropharyngeal airway, again, a small one called Guidel. You measure it and you put it in. And if not, going forward, if you're not trained to intubate patients, the other thing you can always do is have a supraglottic or a laryngeal mask airway, as they're called. So they are pretty much like ventilators, but they're much thicker, and you can put them straight in without having to look. So airway problems actually are the easiest, probably the easiest type respiratory failures, type 1 or 2, to solve, because as soon as you open the airway, there will be ventilation and the patient will be fine. We said A, B, C, D, E. Coming to B. B is breathing. When we come to B, the things we need to look at is oxygen saturations, what is the respiratory rate, what is the findings on chest examination, a quick chest examination, and maybe look for a bit of edema as well. And how does the patient look? Do they look cyanotic? Are they blue? Is their tongue blue? Or are they peripherally blue? Do they look like they're having an extremely hard work of breathing or not? And if anything is yes, then you might be looking at a patient with respiratory. There is the risk that you do not have an arterial blood gas measuring device in where you're working. So you will be completely dependent on saturation targets. Currently, the advice is that if you can maintain saturation above 92%, the patient should be fine. For patients with chronic hypercapnia, like COPD, neuromuscular dystrophy, a target of 88 and above is actually good enough. If you do not know the history well, it is better to take it at 92 and above and then titrate it down if the patient is becoming very drowsy or is developing a carbon dioxide flap, where if you put their hands out like this, they start flapping. So if they don't, otherwise maintaining saturations of 92% and above is our target if you do not have blood gas analysis. If you have blood gas analysis, maintaining targets of partial pressure of oxygen greater than 8 kilopascal or greater than 60 millimeters of mercury, depending on which one your center uses. The breathing section is quite important because your examination will reveal lots of different things about what is going on. For example, if you listen to the chest and there is a lot of wheeze or rhonchi going on, you're probably it's very likely suggestive that there is quite significant asthma, or maybe infective exacerbation of COPD, or even non-infective exacerbation of COPD. And the only way we can treat that is obviously by giving bronchodilators, salbutamol, ipratropium, nebulize the patient, give them oxygen, treat their underlying problem, give them steroid. So with asthma and COPD, there's an easy way. The emergency management is very easy. You give them oxygen, you give them salbutamol, you give them steroid, you give them ipratropium as well is an option. If they're getting more sick, there are other things to consider, but that's more specialist knowledge rather than the emergency initial management. That is your B. The other things to consider in B is things like if you're examining the patient and you hear there's a lot of bibasal crepitations. There are crepitations on both base of the lungs. That is suggestive of edema. And then if the patient is in severe pulmonary edema, you might consider offloading the fluid. The easiest way to offload fluid is by giving something, as long, I mean, again, this is where we are hoping that the person's kidneys are fine, but what we can hope is to offload the fluid by allowing the patient to pass fluid out by giving them some diuretics. So furosemide being the most common thing we use in the UK, but there's lots of other diuretics to use, spironolactone, bumetanide, etc. So in terms of breathing, that is where we are. We examine the chest. We have a look at saturations. We have a look at how the patient is looking. The respiratory rate is their tachypnea, and then we decide it from there. And based on that, we can do our early management. So our early management on the ABCDE pathway is what you see is what you treat. If you hear wheeze, you treat the wheeze. If you hear pneumonia, let's say one side there is a crackle, the other side there isn't, you give them your antibiotics. If you hear there's pulmonary edema, you give them diuretics. It is you treat what you see. We do not have a diagnosis yet. You know, emergency medicine, you will most likely not have a diagnosis until much further out. So the initial part is actually saving the patient, and saving the patient does not need a diagnosis. You do what you see, you treat what you see. So that is B. The other thing to consider is obviously as to, I mean, if it's obvious what's going wrong with the patient, then you can obviously make a quick referral. Is there some pneumothorax? Is there some, you know, if that's what you're seeing, and it's obvious, then you can do a chest drain, etc. That's part of. Okay. So we have done airway, we've done breathing, and then we come to C. C is circulation. Now, circulatory problems can often cause respiratory failure, the commonest being acute myocardial infarction. And in fact, I have been not caught out, but I have had quite a few patients now who came in initially with respiratory failure, especially diabetic patients. And we know Bangladesh is full of diabetes. Diabetic patients who will come in with respiratory failure, but actually what happened was they had an MI. They had a myocardial infarction, and probably a silent myocardial infarction because the patient has no history of the pain. So what we do in circulation is we do a few things. We see what the capillary refill is. Are they perfusing themselves enough? Because the capillary refill time, you know, when you learn your examination, that is something you probably don't take it that seriously. In emergency medicine, that is probably one of the most important things to us, because the capillary refill is, you know, when you don't have any investigations done, you know, first line, when you're seeing the patient the first time, capillary refill is probably your surrogate marker for end organ perfusion. Is a patient, are they perfusing their organs? Is you see by capillary refill time. If the capillary refill time is less than 2 seconds, perfect. There's blood at the end. You know, there's enough blood in the capillaries. If the capillary refill time is about 7-6 seconds, then you know that, you know, there is a problem. There is a circulatory problem as well, and the patient might be in shock. You measure the heart rate. Most patients will be tachycardic if they're breathing very heavily, but you know, if they're not, then it's important to consider why. Blood pressure is a good measurement again of end organ failure. You know, if the blood pressure is dropping, the patient is going into shock. Patient is going to go into multi-organ failure. The other thing to consider, especially with blood pressure, is in patients who have had MI or who have had a pulmonism, is they might often have very low blood pressure. The difference is the management will be very different. I know I'm talking about respiratory failure, but just a quick nitbit. In acute MI, you're afraid of heart failure, so you don't want to flush them with intravenous fluid. You want to give them titrated fluid. You want to maintain their blood pressure a bit lower, as in a low normal, and you want to treat the heart attack. But in a pulmonary embolism situation is the other way around, because in a pulmonary embolism, you don't have enough blood going to the lung. The rest of the body is fine. So what you want to do is you want to fill the patient. You want to give them more fluid. You want to give more intravenous fluid so that enough flow going into the lung to allow more ventilation to happen while you treat the pulmonary embolism as well. However, the main thing about circulation in respiratory failure is doing an ECG. You see, an ECG is very helpful if it's showing either a right-sided or a left-sided problem. If there's signs of right heart strain, right ventricular hypertrophy, we're thinking of a lung problem, whether it's COPD, whether it's pulmonary embolism. It's a lung problem that's being on the heart. So we know this is serious respiratory failure. This is affecting the heart. It is affecting the rest of the body. This patient is serious. If it's a left-sided problem, if you see a left bundle branch block, if you see ST elevation, if you see left ventricular hypertrophy, you're thinking that actually the respiratory failure probably came next. It was the heart that was the problem. And that's where you can do. If you guys are trained, if you are, these days a lot of people are getting trained in end of the bed ultrasound or point of care ultrasound as it's called. An echo is very good part of C as well. Just going back, you might be wondering that I did not talk about oxygen in B. We will go back to it. We'll talk in depth about oxygen therapy because that is the mainstay of respiratory failure treatment. Okay, moving forward, D and E are less important in respiratory failure, but quite good. D is disability. There's two things we look at mainly. It's glucose, what is the capillary blood glucose, which doesn't really make much difference in respiratory failure, except if the patient is very hypoglycemic. If the patient is hypoglycemic, they might have respiratory depression, which might cause type 2 respiratory failure. So that's one thing to consider. The second bit of D is GCS. And again, very important, if a patient has had stroke, if the patient has had something neurological happen and their GCS and they're more drowsy, they're more likely to go into respiratory depression and have respiratory failure. E is exposure, when you look at the rest of the body to find if there's anything wrong. Mostly is not very useful in respiratory failure, except if you see signs of a rash. It could be suggestive that the patient has an anaphylactic shock, an allergic reaction, possibly. That's the only thing. Okay, we've gone through a bit of assessment of patient in quite detail. I hope that's easy to remember. But it's always, whenever you're struggling, go back to A, B, C, D, E. What's the airway doing? What's the breathing doing? What's the circulation doing? Does the patient have any neurological disability? If you expose the patient, is there anything to see? You expose the patient and you see there's a knife into their right intercostal space, let's say right seventh intercostal space. You know what the problem is. You know, it's the respiratory failure is due to a trauma. No, it's not due to anything else. So those kind of things. In terms of investigation, if we come to investigations, the close investigations, end of the bed investigations, that we do is the most important is saturations. Saturation of oxygen is the one thing that you can do anywhere. You can be in Bhola, you can be in Dhaka, you can be in Pabna, you can be at the top of Everest. But there's one thing that a doctor can do is saturations, because all you need is a saturation machine, and most of them are quite small, quite handy, and not very expensive either. The second end of the bed thing that we can do, which are easy, is ECG. Again, ECG, most places will have ECG machines, and you can easily do an ECG. And then the other main ones that we need to consider, but these are more difficult to get, and you are more likely to get them either in an intensive care setting or in a high dependency setting, are things like arterial blood gas, end-tidal carbon dioxide, which you can attach onto the masks, etc. And then obviously you do the rest of your, you do your complete blood count, your CBC, D-dimer, troponin if required, and all the other blood tests that come later. Chest x-rays are very important. So mainly the mainstay of treatment at the emergency level is the chest x-ray, ECG, ABG. If you can get these three, you're done. And saturation of oxygen, the main four. If you can get more than that, that's fantastic. But it depends on where you're working. Within the UK, for example, I have worked in a hospital where I can get a blood test result back in 15 minutes. I've worked in hospitals where at night, if you do a blood test, you have to wait 6-7 hours to get a result. Psychiatric hospitals, for example, will have no tests available. So it depends very much on where you are and how much you can do. Okay. We talked briefly about targeting the saturation, but as I said, the ideal target is above 92% oxygen when we give oxygen therapy. But in chronic hypercapnic patients, hypercarbic patients, like COPD patient, above 82 can be considered. Okay, now giving oxygen. Oxygen, oxygen, oxygen. That is what you need in respiratory failure. Either the problem is you're not getting enough oxygen in, or the problem is there's not enough oxygen diffusing into your blood. So that's the two problems you need to sort out. Now, oxygen delivery, there's been a lot of confusion, especially since COVID came around. There's been a lot of about how we manage it, etc. Oxygen therapy is very simple. You give oxygen like you give any drug, optimal. You know, if someone has a heart attack, you give 300 milligrams of aspirin. You do not give them 2,000 milligrams. You give them 300. If someone has pneumonia, you give them, let's say, meropenem, you'll give them 1 gram, maybe 2 gram, 3 times a day maximum. You will not give them 10 gram. Oxygen is the one drug where we think that if we can just shove something at someone, it works. We don't need to. People will be targeting saturation of 100%, 98%, 96%. No need. We target a saturation of 92% and above, and whatever oxygen is needed, just give them. So oxygen delivery is done in 2 ways. One is where we measure the liter of oxygen we are giving per minute, and the other is in the fraction of oxygen given in that air. So when we breathe in room air, we have 21% oxygen, FiO2 of 21%. So the first thing we start is with nasal cannula, the one that goes into the nose. So easy. You can give 2, 4, or 6 liters of oxygen via nasal cannula. 2 and 4 is more easy. 6 is a bit difficult, but you can try. But you can go from anywhere from 0.5 to 1 to 1.5, 2.5, you know, so you can do the 0.5s as well, as long as your oxygen cylinder has that measurement. And if you can give the right amount of oxygen to maintain saturation above 92%, then you can focus on every other thing that's the problem. You can focus on what happened. If it's an MI, you can treat the MI. If it's a PE, you can treat the PE. If it's pneumonia, you can give them their antibiotics. But the oxygen therapy, you target greater than 92%. You just have to measure regularly to see if the need is going up or down. So nasal cannula is our initial. It usually has about 24 to 28% FiO2, but it can go up as well depending on how good the patient is complying, etc. The second level is what we call the Venturi mask. It is the normal oxygen masks that we have. And some Venturi masks will come with various different settings. So in COPD patients, we usually advise to give oxygen via 24% Venturi or a 28% Venturi, because we don't want to give them, we want them to get good oxygen, but not too much. But usually you can go up Venturi masks from 24, 28, 35, 40, 60, and up to 60% of oxygen. And it all depends on the valve that is attached at the bottom of the mask. So you have the mask, and you have a valve underneath, and then you have the pipe that comes onto the valve. So the valve decides how much oxygen you're going to give. The benefit is, that is the percentage of oxygen you're giving. In terms of the liter of oxygen, you can give 15 liters per minute. So that gives you a great room to give excellent, good flow of oxygen. Okay, so if the Venturi mask is not maintaining, if you go up to about 60% of oxygen on a Venturi mask, and it's not maintaining your oxygen, then what you can do is move up to what is called the non-rebreathe mask. So non-rebreathe is the mask which has a bag in front of it. So you touch the oxygen on, you fill up the bag, that bag acts like a reservoir, and then you put the mask on. That bears about 15 liters of oxygen per minute at 85%. So it's very good. And if you can get a good 90% as well, if it seals around the patient's mouth very nicely. But often it's difficult, you know, someone like me with the beard, people's face shapes are different, so seal is difficult, but usually smaller people get seal and you can get a good seal. So that's the non-rebreathe mask. Most patients, and I tell you this, 85 to 90% of patients will not need to go beyond this. Actually more, 95% of patients will not need to go beyond the non-rebreathe. This is all you need. You need either nasal cannula or a Venturi mask or a non-rebreathe mask, and you can keep it at that. However, if you need to go further, there are 4 other options. One that became very popular, especially in Bangladesh over COVID, was HFNC or HFNO, high flow nasal oxygen or high flow nasal cannula. This is basically a machine that delivers really high pressures of oxygen, so about 60 liters a minute, or even 80 liters a minute, but only via nasal cannula. So this can give a good, again, 85, 90% FiO2 with good pressure of oxygen. So it helps open up the airways. It gives a bit better rush of oxygen. And if you're struggling to maintain saturation, or if you're struggling to maintain a PaO2 of greater than 60 millimeters of mercury, that is what you could try to use. The problems that stay with HFNC or HFNO is the machines are usually quite difficult. It uses up a lot of oxygen. And for resource-limited settings, it might be a difficult thing to use. And also, there's a lot of loss because it's a nasal cannula. They can have a lot of loss of air, and aerosol generation is another issue with COVID going around. The next step up, which I think for Bangladesh is a really good step up, is CPAP. It's continuous positive airway pressure. So what you do here is you send air at a certain pressure, 8 centimeters of water, 10 centimeters of water, 6 centimeters of water, and a certain pressure to shove air into your lungs. The idea is, theoretically at least, that it helps open up the alveoli, helps increase the ventilation of gases. Now, if the CPAP doesn't work as good, CPAP is, the benefits of CPAP are it's actually a much cheaper machine. If you have a good mask with a good seal, you can give 100% oxygen. And also, it can actually be very helpful, especially in COVID. We've seen that CPAP has been dramatically helpful. It's also helpful in cases of patients with pulmonary edema. It helps pass oxygen quite well. And most patients, again, before we just jump in and just ventilate patients, put them on a ventilator. Now, we have all these non-invasive ventilators like CPAP. So CPAP is like ventilating a patient while keeping them. And we can use this as our go-to as well. The next step up is what is called a BiPAP. It is biphasic airway pressure. So it gives you a pressure on inspiration, and it gives you a pressure on expiration as well. So it helps it's most useful in hypercarbia or hypercapnia because it helps get rid of excess carbon dioxide. So if a patient is COPD, you might want to miss CPAP and go directly to BiPAP. That is what you could think of. And actually, that is the main thing where BiPAP is actually superior to CPAP, is in this one thing where you have hypercapnia, when there's a lot of carbon dioxide in the body and you want to get rid of the carbon dioxide. Okay, the next step up in terms of oxygenation is mechanical ventilation, which is, as we know, intubation and ventilation. You paralyze the patient. You don't always need to paralyze. Sedate the patient, anesthetize them. You put an ET tube into their airway, and you ventilate them with the machine. It can be done in two ways. You could do pressure support, where you support a certain amount of pressure, or pressure control, where you control the pressure that the patient himself or herself is taking their breathing. So that's more or less how you give oxygen. There's another option, which I know we do not have in Bangladesh, but academically is important to know. It's called ECMO, ECMO, extracorporeal membrane oxygenation. It can be done for various reasons. For cardiac surgery patients, they do it for other reasons. But for oxygenation purposes, in respiratory failure and patients with acute respiratory distress syndrome, where not much of the lung is there to recruit oxygen, what you can do is you can take you take two lines out, you take blood from the vein, from the femoral vein, and then you put the blood into your internal jugular vein, and you oxygenate the blood in a separate machine. And ECMO patients can actually be awakened as well. You can wake them up. You don't need to keep them ventilated on the machine, because the machine is oxygenating their blood outside their body. It's an extremely expensive procedure. It's about 8 to 10 members of staff for each patient, because you need nurses, you need physiotherapists, you need an ECMO machine technician, and there's a lot that is difficult. However, if ECMO can be done, it is extremely vital, especially in patients with acute respiratory distress syndrome. because what happens in those patients is because they don't have much lung. So you allow the lung to recover while you're oxygenating them on a machine. So that is a lot of discussion about respiratory failure. We cannot go through respiratory failure in just one session, especially with the number of causes there are. However, we just wanted a very brief outlook. This is a conference after all, and we do not want to buzz you with too much information. So I wanted to keep it basic. Of course, if you go into any books, there will be a lot more to see. Books I would often suggest to read, especially for emergency management and things, would be Oxford Handbook of Emergency Medicine or Oxford Handbook of Critical Care Medicine, although it's different, but critical care medicine will talk in a lot more detail about respiratory failure. Otherwise, our usual medicine books, Kumar and Clark, Davidson, are quite good as well. And in terms of the basic things to remember is respiratory failure is when there's hypoxia. When there's acute hypoxia, the oxygen levels are coming down, you think that the patient has respiratory failure, whatever the cause. Then you think of the differences. Is it type 1, type 2? Is it just hypoxia, or is it hypoxia with hypercarbia? And then you think of doing an ABCDE assessment of the patient to determine what the initial cause is, and you start early treatment and early management. Of all the failures, heart failure, liver failure, renal failure, respiratory is the one failure you'll see the most in your careers. It happens to patients of every different systems, and that is why this is one thing that we all need to know. And the majority of patients we see in the emergency department, even in the United Kingdom, is respiratory patients, among all others. And that is actually going to be the norm, no matter where we go, except for some parts of the year. For example, in Bangladesh, when we have at the diarrhea season, we might not see that many respiratory patients. But again, a severe diarrhea patient might develop respiratory failure as well. So that will be it for today. Thank you very much.